Hello everyone, welcome to our second Sleep Talk. Today our speaker, Sherry LaRocque, will be presenting on the topic Cannabis and Sleep. Sherry LaRocque recently finished her PhD in clinical psychology at Queen's University in Kingston. Her research background is in stress and depression, so not related to cannabis at all, but she's always shown an interest in alternative approaches to treatment. For instance, her PhD research was a treatment study looking at the effectiveness of Bikram yoga versus exercise for women with major depression. Sherry's clinical training has been primarily cognitive behavioral in nature, and insomnia and OCD are some of her favorite issues to work with. She's been a part of the HALEO team since 2018 and is excited to be involved in our Sleep Talk series. Thank you for being with us today, Sherry.
All right, thank you, Melissa. And hello, everyone. I'm just going to make a small change on my screen here. All right, so thank you for joining today's Sleep Talk webinar on cannabis and sleep. This is our second Sleep Talk presentation that we're doing, but our first one in English, so we're very excited about that. And I'm also excited to bring you a topic that I think is very interesting today, so hopefully you find it interesting as well. So as you might imagine, with the recent legalization of recreational cannabis in Canada, cannabis and its potential therapeutic effects is a bit of a hot topic right now. So there's a lot of information floating around there. There are plenty of claims that this particular strain or that particular strain have been proven to help with things like sleep, mood, anxiety, and so on. So in order to evaluate all of this information, we need to turn to the research that's been done on the potential effects of cannabis. And that's what I'm going to focus on today when talking about cannabis and sleep. Oops. Okay. So here's the agenda for today's presentation. I'm going to talk a bit about what are called cannabinoids and the endocannabinoid system. Then I'll touch on the history of medical cannabis. I'm going to give you a brief overview of sleep, so our sleep-wake cycle and the stages of sleep that we go through. And this is important simply because I'll be referring to some of these aspects later on in the presentation. After that, I'll be talking about the effects of cannabis on sleep in general. And then finally, I'll talk about the use of cannabis for two of the more common sleep disorders, insomnia and obstructive sleep apnea. So when we talk about cannabis, we have to talk about what are called cannabinoids, because cannabinoids are the active chemical compounds found within the cannabis plant. So these types of cannabinoids are technically called phytocannabinoids. Phyto meaning from the plant. And there are two types of phytocannabinoids that you've probably heard of, THC and CBD, which I'll talk about in a bit. But the cannabis flower actually has over 100 different types of cannabinoids. So phytocannabinoids were actually the very first type of cannabinoid ever discovered, but we also have endocannabinoids and synthetic cannabinoids. So endocannabinoids are cannabinoids that our own bodies are producing all of the time. They're produced in the brain, and then they circulate throughout the body and have very widespread effects. Synthetic cannabinoids are those that are made in the lab. So they're made to mimic the actions of naturally occurring cannabinoids. And synthetic cannabinoids have been really helpful in terms of research aimed at better understanding the effects of cannabis and cannabinoids in general, including their therapeutic effects. So all of these different types of cannabinoids act on the endocannabinoid system of our bodies. The endocannabinoid system, which I'm going to try to refer to as the ECS because it's quite wordy, is part of our natural physiology. So it's a biological system that's involved in regulating a variety of physiological and cognitive functions in the body. So things like our appetite, our mood, memory, pain, pleasure, stress, response, inflammation, fertility, etc. So lots of things. And it kind of helps all of the systems in our body work together and maintain balance. And the ECS is able to do this and have such widespread effects because we have what are called cannabinoid receptors located all throughout our bodies. We have them in the brain, we have them in the rest of our nervous system, we have them in our organs and in our immune cells. So there are two main types of cannabinoid receptors in our bodies called CB1 and CB2. We have the highest density of CB1 receptors in our brain, and CB2 receptors are found primarily outside of the brain. So what happens just naturally in our bodies is that when endocannabinoids are produced in the brain, they get released, they circulate throughout our body and our bloodstream, and they bind to cannabinoid receptors. Now, not every endocannabinoid is going to bind to every receptor. There's some specificity. So you can kind of think of this like a lock and key. The key is the endocannabinoid, and the lock is the receptor. And if they fit together properly, the door opens, or rather, a specific physiological or cognitive function happens in the body. For instance, when we haven't eaten in a while and our energy levels are depleted, which is, anandamide, which is one of our naturally occurring endocannabinoids, is produced, and it binds to CB1 receptors in the brain, and this stimulates our appetite. So when an endocannabinoid and a cannabinoid bind together, the effect that happens is going to depend on the endocannabinoid, the type of receptor, and where in the body this binding is happening. Sorry, just one second. So this is a system that we all have built into us. And it's a system, on one hand, that really has nothing to do with cannabis. The thing is, some of the phytocannabinoids found in cannabis can also bind to these receptors, resulting in various effects in the body, as can those synthetic cannabinoids. The two most well-known and well-researched phytocannabinoids are THC and CBD. They are also the most abundant cannabinoids in the cannabis plant. So THC stands for delta-9 tetrahydrocannabinol. No wonder it's called THC for short. And it's the psychoactive component of cannabis. So it results in things like euphoria, hallucinations, anxiety, and tachycardia, or a faster than normal resting heart rate. CBD stands for cannabidiol. It's considered non-psychoactive, meaning that you don't get a high from it. And it's been found to counteract the effects of THC. So it's received quite a bit of interest recently for its therapeutic potentials. So how is there this difference between them? Like, they look pretty similar. But if you look at diagram, which is showing their molecular structures, you can see that their structures are actually quite different. So things are kind of arranged in different ways. And thinking about that lock and key analogy, this difference in structure essentially means that the key for THC and the key for CBD are different shapes. So when we consume cannabis, THC and CBD are absorbed into our bloodstream, and they'll make their way through our body searching for cannabinoid receptors. But because their molecular structures are different, they're not going to bind to the receptors in the exact same way, or to the same receptors for that matter. So THC is a very strong activator of the ECS. It acts primarily on CB1 receptors, which, remember, are located mostly in our brain. And these receptors are found in brain regions responsible for mental and psychological processes like memory, cognition, emotional responses, motor control, and feelings of reward. THC also binds to CB2 receptors, but to a lesser degree. Now, CBD's activation of the ECS is weaker, and it's a bit more complicated. So it's believed to act on CB2 receptors to some degree, but its effects are now thought to be largely indirect, perhaps by affecting THC's ability to bind to receptors. So I'm not going to get into this further because it's complicated and researchers are still sorting it out. But just know that because the molecular structures of THC and CBD are different, they act in different ways on the ECS, and this results in different effects on the body and mind. So here's a comic that I found and thought was pretty funny. And you can all have a laugh over there. I don't know. I can't see you or can't hear you, so I don't know if you're laughing, but hopefully you are. So cannabis is really interesting from a therapeutic standpoint when you consider the function of our built-in ECS, which is to maintain balance in the body. And generally, our ECS does a pretty good job at this. So it knows what endocannabinoids to produce and when. However, there are cases when people may have an imbalance in their ECS or could benefit from having more cannabinoids in their system. For instance, people who are undergoing chemotherapy, they often complain of poor appetite, they have a lot of nausea, they lose significant amounts of weight in addition to other things. So there may be an imbalance in their ECS due to the chemotherapy or the cancer itself. So by using cannabis, they're able to restore some balance in their ECS. For instance, we know that THC, like anandamide, one of our naturally occurring endocannabinoids, acts on CB1 receptors in the brain to stimulate appetite. And in this case, cannabis would have important therapeutic effects for someone. So medical cannabis, what a neat idea. Well, even though it might seem like a relatively new idea, this idea of medical cannabis has actually been around for a long time. So cannabis has been used for its therapeutic benefits, especially for its pain-reducing and anti-nausea effects for over 5,000 years, so dating back to ancient times. In the Western world, cannabis became widely used as a medicine in the 19th and early 20th centuries. It even appeared in the United States Pharmacopoeia in 1850 as a treatment for tetanus, typhus, cholera, rabies, alcoholism, gout, snakebite, excessive menstrual bleeding, tonsillitis, insanity, incontinence, like literally everything under the sun. However, in the 1930s, the use of cannabis was subsequently criminalized. The molecular structure of THC was discovered in the 1960s, which led to synthetic THC being produced for the first time in the 1970s. And this allowed researchers to start examining the effects of THC. This research led to the discovery of those cannabinoid receptors that I was talking about, to the endocannabinoid system, and finally to those endocannabinoids that our brain produces. Around the same time, recreational use of cannabis was on the rise because laws regarding marijuana use had kind of relaxed. And this led to numerous anecdotes about the therapeutic effects of cannabis, especially from cancer and AIDS patients. These anecdotes couldn't be ignored anymore, and in the late 1990s, California became the first US state to legalize medical cannabis. And today, 33 states and the District of Columbia have legalized it for medical purposes for specific conditions. Canada followed suit in 2001, legalizing access to cannabis for individuals with terminal illness or other severe conditions like multiple sclerosis, cancer, HIV, and arthritis. And of course, now recreational use is being legalized in Canada. So I think we're going to see a huge increase of research into the potential medical and therapeutic effects of cannabis. Now, relevant to this talk, I'll just mention that a recent survey from the US found that among medical cannabis users, almost 50% reported using cannabis to help improve their sleep. But before I get into that, I'm going to have a sip of water, and I'm going to give you a brief overview of our sleep-wake cycle and the stages of sleep. And remember, this is, I think it's interesting, but it's also important because I'll be alluding to some of these aspects later on. So our sleep-wake cycle refers to our daily pattern of alternating sleep and wakefulness. It consists of roughly 16 hours of daytime wakefulness and 8 hours of nighttime sleep. And it's controlled by two main biological processes that we have built into us, kind of like the ECS. So one is called the homeostatic process. So homeostasis, it might be something that you've heard of before, but if not, it's a process by which our body maintains a steady state of internal conditions such as blood pressure, body temperature, and so on. So these things, they do fluctuate naturally throughout the day a bit, but they're not all up and down. So there is, a steady state to them. Now, the amount of sleep that we get each night is also under homeostatic control. So from the time we wake up in the morning, the homeostatic sleep drive, or drive for sleep, which is shown by the S in the diagram here, it starts to increase, reaching its maximum in the late evening when most individuals feel sleepy. And when we're at our maximum, it becomes more and more difficult for us to stay awake and resist the drive to fall asleep. And when we go to sleep, this drive for sleep decreases across the night. The second process involved in our sleep-wake cycle is called our circadian rhythm. So this is basically our 24-hour internal clock that's always running in the background in our brain. And it's responsible for daily fluctuations in things like sleep and wakefulness, our hormone levels, body temperature, blood pressure, and so on. And this internal clock is synchronized with our external environment, particularly with light. So exposure to light and darkness are external signals that set our biological clock and help determine when we feel the need to wake up or when we feel the need to go to sleep. So these processes, I won't get into it further, but they interact in regulating our sleep-wake cycle. So even though we tend to think of sleep as this time of shutting down or shutting off, it's actually a very active process that can be broken down into several different stages. And these stages differ in terms of things like brain activity that's happening, movement in the body, our breathing rate, heart rate, blood pressure, eye movements. And during an 8-hour period of sleep, someone with normal sleep will cycle through these different stages about every 90 minutes or so. Before I get into the individual stages, I'll just mention that there are two types of sleep. We have rapid eye movement sleep, also called REM sleep, and we have non-rapid eye movement sleep, or non-REM. So non-REM has several stages within it, and these are the stages that we move through first when we fall asleep. Non-REM in general is characterized by a reduction in physiological activity in the body. So brain activity starts to slow down, breathing and heart rate gets slower, blood pressure drops, eye movements slow down, and then they stop. Okay. Stage N1 is the first stage of non-REM sleep, and it's very light sleep. It's essentially the transition from being awake to falling asleep. And as I mentioned, things start to slow down physiologically, but a person in this stage is actually still quite aware of their external environment, so they're easily woken up. If you've ever had that experience when you feel like you're kind of falling asleep, but then you jerk yourself awake, it's probably happened in this stage. Stage N2 is slightly deeper sleep, but it's still considered light sleep. In this stage, things start to slow down even further and eye movements stop. Brain waves become even slower, but there are occasional bursts of activity called sleep spindles, and it becomes harder to wake a person up in this stage. Stage N3 is deep sleep, also called slow wave sleep because of the slow brain waves, the delta waves that happen. You can see these delta waves, which I'm showing on the right-hand side here, are quite slow in comparison to the alpha waves that we have when we're in relaxed wakefulness. So in stage N3, body temperature, blood pressure, and breathing slow even more. There's no eye movement and not much body movement, but muscles are still able to function. And this is the most difficult stage to wake a person up from. And if somebody is awoken from this stage, they typically report feeling quite groggy, disoriented, or just kind of yucky for a bit. And stage N3 is really important because it's a restorative phase of sleep. So this is when the body really heals and repairs itself, when energy is restored, when growth and development happen, our immune system is quite active. And finally, REM sleep is really interesting because it's actually a very active phase of sleep with lots of things happening in the body. So brain activity increases. You can see on the right-hand side that the brain waves in REM sleep actually look more similar to those alpha waves that we have in relaxed wakefulness. As well, our heart rate and blood pressure increase, our breathing can become quite fast and irregular, and this is the stage that we do most of our dreaming in. Along with that, our eyes move back and forth underneath our eyelids. And this is because they're actually following what's happening in our dreams. And our bodies are essentially paralyzed because we don't want to be acting out our dreams. Here I'm just showing how we cycle through those stages of sleep across a single night. So we call this our sleep architecture. And typically each cycle takes between 90 to 110 minutes. Just looking at the different stages, they're kind of presented in different order here, but I'll kind of walk you through it. So you can see that stage N3, that deep sleep, takes up a lot of time in the cycles towards the beginning of the night, but it takes less and less time in a cycle as the night goes on. In contrast, REM sleep, which is just under awake there on the left-hand side, REM sleep, as well as stage N2, that light sleep, they take up more and more time as the night goes on. So we get most of our deep sleep towards the beginning of the night, and we get more dreaming in and more light sleep towards the end of the night. All right, with that background in mind, which you hopefully found interesting, let's get into talking about what we're really here to talk about today. So how does cannabis impact our sleep? As I mentioned, improving one's sleep is one of the most commonly reported reasons for using medical cannabis. And considering that approximately half of the men and women in Canada report sleep difficulties, I think that this is a really relevant topic. So I have a few other quick points here from research that I'll quickly highlight, and then I'll get into things in a bit more detail. So from Walsh and colleagues, in a large sample of medical cannabis users in Canada, sleep problems along with pain and anxiety were the most commonly reported reason for using cannabis. Another group of researchers found that 48.1% of medical cannabis users reported using it for insomnia symptoms. So if so many people are using it, there's got to be a good reason, right? Well, one group of researchers found that among medical cannabis users, both those with and without a sleep disorder, reported that cannabis decreased the time taken to fall asleep. And Piper and colleagues found that among those who use medical cannabis, 65% reported decreasing their use of sleep medication once they started using cannabis. So today, I will tell you about some research findings that have been found. Just to be upfront about things, this is an area of research that is really in its stage So there are a lot of mixed findings. There are a lot of things that we still don't know. And I think this speaks to the importance of having some healthy skepticism about the therapeutic effects of cannabis, rather than just jumping on the CBD oil bandwagon that a lot of people seem to be jumping on. Okay, so let's first look at how cannabis affects sleep in general. There have been two main periods of research done in this area. So there's been a more recent one done in the last 10 to 15 years, but the first period of research on cannabis and sleep happened in the 1970s when synthetic THC was first produced. So research at this time included mainly adult men who were recreational users of cannabis, and what the researchers did in general was administer certain dosages of THC to these men and examine how that THC affected their sleep. So they were interested in objective measurements of sleep. So these would be sleep, different aspects of sleep that are measured by certain equipment or monitors, such as the amount of deep sleep a person gets, the amount of REM sleep, how long it took to get to that first REM period. So in these studies, they would be basically connecting a whole bunch of things to the person and measuring their physiological activity. So those brain waves, breathing rates, and things like that. Some studies found what I'm calling positive effects on sleep. So researchers found that THC increased the amount of deep sleep a person got, increased the amount of REM sleep, decreased the time taken to fall asleep, decreased the time spent awake during the middle of the night, and decreased feelings of sleepiness the next morning. So to me, all of these things sound really good in terms of sleep. However, other studies found the opposite effects, which I'm calling negative effects. So they found decreases in deep sleep and REM sleep, increased time to fall asleep, increased time awake during the middle of the night, and increased sleepiness the next morning. Making matters even more confusing, some studies found no effects on some of these sleep variables. So, as I warned you, research looking at the effects of cannabis on objective measurements of sleep is really, really mixed. Since the 1970s, there's been a few more studies done that have looked at the impact of cannabis on objective sleep measurements, but they haven't really added to our understanding. Part of the problem is that, without getting into the details of it, the methods used in these studies have been pretty poor. As well, the studies have varied in terms of things like the dosages of THC used, the timing of administration, the route of administration, and how much cannabis or other substances that people are using on their own time. So no wonder the results are so mixed. So what I think we can take away from this is that when it comes to objective measurements of sleep, cannabis might have an impact. But whether it's improving our sleep, making things worse, or doing some combination, we don't really know at this time, for sure. So this brings me to research that's been done more recently in the last 10 to 15 years. These more recent studies have generally focused on self-reported sleep or subjective measurements of sleep. So these are an individual's own report of their sleep, in contrast to measurements made by some piece of technology. And here we're talking about the effects of cannabis-based medicines, so either synthetic cannabinoids or specific extracts from the cannabis plant used for some therapeutic purpose, typically for chronic pain, multiple sclerosis, cancer, or HIV. There's been a lot more research done on the use of cannabis for these conditions, especially chronic pain, and many of these individuals suffer from sleep problems as well. So these studies have generally found positive effects of cannabis-based medicines on sleep. Participants report decreased sleep disruptions, less time taken to fall asleep, increased quality of sleep, increased feelings of restfulness, and just an overall improvement in sleep. A few studies here and there have found no impact of cannabis on some of these sleep variables, but overall, the research in this area suggests that people who take cannabis for medical purposes believe that it helps with their sleep. And this seems to be the case for medicines made to mimic the actions of THC or CBD or a combination of the two. It's important to note, however, that these studies haven't found any evidence that cannabis-based medicines actually increase the amount of total time of sleep that somebody gets. So what can we conclude about the effects of cannabis or cannabis-based medicines on sleep in general? When it comes to objective measurements of sleep, it appears that cannabis may have an impact on various aspects, including our sleep architecture. However, given the very findings and the quality of most of these studies, researchers are not in a place to draw firm conclusions about any of this. What needs to happen is more research and good quality research. So research that uses proper methods, that looks at both objective and subjective measurements of sleep, research that examines the effects of short-term versus longer-term use of cannabis, and research that looks at these questions in cannabis-naive individuals, so people who aren't using cannabis recreationally. Despite the mixed findings, I think that more research in this area is definitely warranted. So recently, it's been shown that the ECS plays a regulating role in the circadian part of our sleep-wake cycle. It's also been shown that administration of THC and CBD affect different components of our sleep-wake cycle. So I think there's really good reason to further examine the impact of cannabinoids and cannabis on sleep. We just need that research to happen. When we're looking at subjective reports of sleep, cannabis appears to be helpful for people with a pre-existing medical condition that might be negatively impacting their sleep, like chronic pain. So basically, these people see it as helping their sleep, which is a good thing. However, at this point, it's unclear whether cannabis directly improves sleep or whether it's more indirect. That is, does cannabis improve the symptoms of the pre-existing medical condition, which then has a positive impact on their sleep? So there's some evidence at the moment to suggest that this is the case, this second point, but more research is needed to tease this apart. All right, so let's move into talking about the use of cannabis for insomnia, which is the most common sleep disorder. Most people will experience symptoms of insomnia at some point in their lives. It's often acute, so just lasting for a short period of time. But for about 10 to 15% of the population, the symptoms are chronic, meaning that they last for at least 3 months, but often for many months or many years. Insomnia is characterized by a dissatisfaction with the duration of sleep or the quality of sleep. So it's associated with difficulties falling asleep, maintaining sleep, or waking up too early in the morning and being unable to fall back asleep. It causes significant distress and impairment for people, and understandably is often associated with daytime daytime fatigue. And despite what I said earlier about 50% of medical cannabis users using cannabis for insomnia symptoms, there's been very little research done in this area. So here's a graph from a Canadian study that was done in 2010. The researchers were interested in the effects of nabilone, which is a synthetic form of THC, on insomnia symptoms. They looked at this in adults with fibromyalgia. So fibromyalgia is a chronic pain syndrome, and people with this often experience insomnia as well. The researchers were interested in comparing the effects of nabilone to those of amitriptyline, which is an antidepressant medication that is often prescribed to treat fibromyalgia-related insomnia. So this graph here is showing scores on the Insomnia Severity Index, or the ISI, and this is a commonly used measure of insomnia symptoms. So higher scores on this indicate greater symptoms or more severe symptoms, and lower scores represent less severe symptoms. So the baseline bar on the left is showing the initial average for all participants on the ISI. And on the right, you'll see 2 gray bars. So this is after 2 weeks of treatment. And there are separate bars for the nabilone group and the amitriptyline group. And you can see that those in the nabilone group had lower scores than those in the amitriptyline group, which means that those in the nabilone group experienced a bigger improvement in their insomnia symptoms compared to the other group. Now, you might find these results exciting, but keep in mind that this is only showing data for 2 weeks. So this tells us nothing about the longer-term use of cannabis for insomnia. Recently, an interesting study from the US was published examining the use of natural cannabis on insomnia symptoms. So not synthetic cannabis or even cannabis extracts, but cannabis in its natural plant form. And the researchers were also interested in various characteristics of the cannabis plant and how those related to changes in sleep. For instance, they looked at the 2 main species of cannabis plant. So there's cannabis sativa and cannabis indica, as well as cannabis hybrid, which is basically a plant that is derived from breeding cannabis indica and sativa together. So you get a hybrid. And they looked at different strains as well, which are basically different types of sativas, indicas, and hybrids. Among the 409 participants in the study, the researchers found an overall improvement in insomnia symptoms. The degree of improvement was dependent on several things, including the main type of cannabinoid in the product, the plant subtype, and the method of consumption. So products with a greater concentration of CBD were found to be more effective than products with more THC. Products from the C. indica plant or hybrid plants were found to be more effective at improving insomnia symptoms than products from the C. sativa plant. And finally, the use of vaporizers and pipes was found to be associated with greater symptom relief than the use of joints. I'll also mention that products from the C. sativa plant were associated with more negative side effects than the C. indica or the hybrid plant. So these aren't major side effects, but things like feeling kind of foggy, forgetful, unmotivated, having dry eyes, a dry mouth, things like that. And although these findings are interesting and give us some very preliminary insight into the types of products that may be most helpful for people with insomnia, the thing that struck me most was this. So the 409 participants in this study reported using 461 different strains of cannabis. So when you as a potential consumer hear claims that a particular strain of cannabis has been proven to work for X, Y, and Z, just keep in mind that there are so many strains out there. There are thousands of strains out there and not much research. So again, some healthy skepticism is recommended. So as I mentioned, these results are interesting and they show some promise. However, another thing to keep in mind is that daily cannabis use has been linked to higher rates of insomnia and more severe symptoms of insomnia than non-daily use or no use. So what can we conclude about the use of cannabis for insomnia? Well, at this point, not much. The research is it's simply to draw any conclusions at this point. But as I mentioned, I think we'll be seeing a big increase in the amount of research in these areas. So if cannabis is not a good answer for insomnia, at least at this point in time, what is? Well, cognitive behavioral therapy for insomnia is the recommended first-line treatment for chronic insomnia. Some of you might be familiar with what it is, but for those of you who aren't, it's a set of techniques that allows the biological processes, so that homeostatic process and the circadian process of our sleep-wake cycle to operate without interference. It involves restricting the amount of time spent in bed, getting out of bed when you're not sleeping, and having a constant rise time every morning. And these techniques combined help to re-regulate their circadian rhythm if it's out of sync, and they help to build up our homeostatic sleep drive. They also help our brain learn to associate our bed with sleeping rather than being awake and being frustrated. So CBT is a very effective treatment. Benefits can last up to 10 years, but potentially longer. And it's also effective for people who are struggling with insomnia, plus other things like chronic pain, depression, cancer, heart disease, etc. So it's a tried and true treatment for insomnia, whereas cannabis, well, we don't know yet. Only time will tell. All right, so let's move on to talking about cannabis and obstructive sleep apnea, another common sleep disorder. Obstructive sleep apnea, or OSA for short, is characterized by intermittent stoppages of breathing during sleep called apneas. So the apneas happen when the throat muscles and the tongue relax too much to allow for normal breathing. And when this happens, it causes the airway to narrow, which can cause either a partial or complete blockage of the airway. Apneas can last between 10 to 40 seconds. They can happen up to hundreds of times a night, and they can result in low oxygen levels in the blood, at least temporarily. But when they happen, a person's often woken up from sleep, and this allows the airway to properly reopen again. But the thing is, it's kind of interesting, many people with OSA they're often not even aware of their sleep difficulties, their breathing difficulties during sleep or of the nighttime awakenings. As you can imagine, though, people with OSA often complain of non-restorative sleep, so they don't feel refreshed following a night of sleep. They also experience daytime sleepiness and fatigue. And it can take special testing to figure out if you have OSA, which I'm not going to get into, but if you're concerned that you may have OSA or you're concerned that your sleeping partner may, we recommend you speak to your family doctor who will point you in the right direction in terms of treatment options. Similar to insomnia, there's only been a bit of research done on the use of cannabis for OSA, half of which has been done on animals. So in the animal research, the researchers figured out a way to cause apneas to occur in these cute little rats. And then they were interested in whether dronabinol, which is a synthetic form of THC, could prevent those apneas from happening despite them triggering them. And they found that yes, injecting dronabinol into the brains of these rats reduced apneas and also increased muscle tone in the upper airway. So the author suggested that this may help stabilize respiration or the mechanics of breathing in rats. There have been a couple studies done with humans which have shown some promise. So here's a graph from one of them. In this study, the researchers had a very small group of adults with OSA who took dronabinol, so that's synthetic THC, nightly for up to 3 weeks, and each week the dose of dronabinol increased. This graph is showing each individual score on the apnea-hypopnea index, which is a measure of the severity of OSA symptoms. And it's showing scores at baseline, so before any treatment happened, and then at week 1, week 2, and week 3. And although the graph looks kind of messy, the researchers found that when the participants were averaged together, OSA symptoms decreased over the course of the 3 weeks. A second study looked at the effectiveness of dronabinol in comparison to a placebo pill, so like a sugar pill that doesn't have any therapeutic effects. And they did this in a bigger sample, so a sample of 73 adults with OSA. And the researchers found that individuals in the dronabinol group, but not in the placebo group, experienced a reduction in their OSA symptoms. However, the reduction was quite small for most participants and not what we call clinically meaningful. And none of the participants experienced an increase in blood oxygen levels like the authors or the researchers predicted. So this idea of using cannabis for obstructive sleep apnea has led to controversy recently, which I found interesting. As I mentioned earlier, 33 US states and the District of Columbia allow for the use of medical cannabis for particular conditions. Well, in 2018, the state of Minnesota added obstructive sleep apnea to that list and approved the use of dronabinol for OSA. So the rationale that they used was based on the animal studies and the 2 human studies that I just presented, which is not much research at all. So since then, and rightfully so, there's been a bit of an uproar about this. So organizations including the American Academy of Sleep Medicine and the Mayo Clinic have released statements regarding the lack of evidence in the area. So here, the American Academy of Sleep Medicine states that medical cannabis and or its synthetic extracts should not be used for the treatment of OSA due to unreliable delivery methods and insufficient evidence of effectiveness, tolerability, and safety. OSA should be excluded from the list of chronic medical conditions for state medical cannabis programs, and patients with OSA should discuss their treatment options with a licensed medical provider at an accredited sleep facility. So those are recommendations coming from the top. In the Mayo Clinic's article, they reiterate these points and they highlight some potential dangers of using cannabis for OSA in place of other recommended treatment options. So in terms of what we can conclude from this, I think it's safe to say that although a very small handful of studies have highlighted the potential therapeutic use of dronabinol specifically for some individuals with OSA, the evidence is really lacking. So we need more research to help better understand if and how cannabis improves OSA, as well as the potential risks associated with using cannabis in this subgroup of individuals. So what else can be done for OSA? Well, the first step in treatment is to talk to your primary care provider or a licensed medical provider so that he or she can point you in the right direction. Perhaps refer you for appropriate sleep testing if necessary. And from there, treatment will depend on the individual and the severity of the OSA symptoms. So for milder cases, sometimes behavioral and lifestyle changes are all that are needed. So things like losing weight, exercising regularly, limiting alcohol and smoking, using a nasal decongestant, sleeping on your side or your stomach instead of your back, things like that. For mild to moderate cases, using an oral device may help because these can help keep your airway open, so that might be enough. But the most common and effective treatment for OSA is a continuous positive airway pressure machine or a CPAP machine. So this type of machine works by providing a continuous continuously blowing pressurized air through a mouthpiece or a nose piece that's placed over this area when you sleep. And this air pressure keeps your airway open, preventing apneas and snoring from happening. And when used as directed, the CPAP machine is really very effective. It can cause immediate improvements in OSA symptoms and improvements to a person's quality of life. But as I mentioned, it's important to speak to your doctor to determine the best course of action. So I'd like to end with an important word of caution that you may have been wondering about throughout this presentation. And this has to do with long-term or heavy use of cannabis and how that affects our sleep. So although some people report that cannabis helps them to sleep better, research has shown that the sleep-enhancing effects that some people experience do not necessarily continue with long-term or chronic use. What happens is that people habituate to the effects of cannabis. So this means that their bodies essentially become used to it over time and its effects diminish. And this may cause someone to start using more and more cannabis to obtain the same desired effects that they received initially. And this could, as you could probably guess, lead to problematic use for some people. So the person kind of gets stuck in this vicious cycle. Perhaps not surprisingly then, research has also shown that among heavy cannabis users, there's an increased risk of insomnia and sleep disruptions. And this is probably because these individuals, they've habituated or developed tolerance to the effects of cannabis. And then there's the whole issue of quitting cannabis and what happens to our sleep then. Although many of the research findings I've talked about today have been quite mixed, this is an area where the findings are actually very solid. So what has been shown is that when people quit cannabis, sleep disturbances are one of the most severe and long-lasting withdrawal symptoms. So people often show a decrease in the amount of sleep they get, a decrease in deep sleep or slow wave sleep, so restorative sleep. It also takes longer to fall asleep. More time is spent awake during the middle of the night, and people often report having strange dreams. So these changes in sleep, they tend to occur or show up within the first couple of weeks of quitting cannabis, but they can persist for as long as 45 days and potentially longer. And as you might imagine, this can cause a lot of people to start using cannabis again because they just can't cope with the sleep disruptions. All right, so just a couple final thoughts and then we'll wrap up. I know this has been a lengthy presentation. So whether a person is just a bit dissatisfied with their sleep or is struggling with something like insomnia or OSA, cannabis probably is not the answer. So sure, some people report that it's helpful with their sleep, and research has corroborated this to some degree. However, when we're talking about objective measurements of sleep relating to our sleep architecture, the evidence just isn't there yet. And given that long-term cannabis use has been associated with a number of negative consequences relating to our sleep, pursuing other evidence-based treatment options, CPT for insomnia, or CPAP therapy for OSA is going to be the best course of action. All right, that's it. Thank you very much, everybody. I hope you found that informative and made it to the end. And we look forward to announcing the date and topic of our next Sleep Talk series. And hopefully we will see you there. So thank you.